Assalamu alaikum warahmatullah.
Waalaikumsalam, Doktor.
Good morning to everyone.
Good morning, Doctor.
How is your study now during online teaching? Are you doing good? Don't waste your time. Don't be lazy, please. You must read at least one reference about pediatrics as you wish. You have a lot of options, and you must be trained on MCQ and other type of questions. And welcome if you need to ask about anything, okay? Today we are meeting just to present two cases for learning about it. So who will be the first presenter?
Me, Doctor. Shamimi.
Shamimi, okay. So start by Al-Kitab, and you have maximum 1 hour for you and your colleague to present that case, okay?
Okay, first, we're going to start with role play. So I'm going to be the doctor, and my patient will be, I will be collecting the parents of one of the patient, which is Nurul Putri. Are you ready, Nuri? Putri?
Can you hear me?
Oh, yes. Okay. Assalamualaikum. Good morning. My name is Shamimi. I'm a third-year student in IUM, and today I would like to plug you as one of the parents of the patient. So may I know how can I address you?
You can address me as Miss.
I'm sorry, can you repeat?
You can address me as Mrs. Putri.
Okay, Miss Putri.
Yes, yes.
Okay. First of all, may I know the patient's name, his age, and also your relationship with him?
My child's name is Abdullah Hasimi, and he's 10 years old, and I am his mother.
Okay. What actually brought him here?
He was actually well before 6 hours before he is admitted to the ward. When he presents with difficulty in breathing.
Is there any other symptoms that come with the difficulty in breathing?
Well, he also have rapid breathing and productive cough.
So does the cough come with any sputum, or is it just a dry cough?
It has whitish sputum, and he also vomits 4 times prior to the admission, and also appeared less active than usual.
Okay, so can you tell me more details about what actually happened? Maybe does anything happen before the symptoms occur?
What I realized is that the symptoms started as before this, one day before, my child had an ice cream and a wedding celebration, and then from there on the symptoms started, and it keeps on progressing and worsened, especially in the evening when he had more severe breathing difficulty, and he also vomits 4 times after the episode of coughing.
Okay. How does his cough sounds like? Does it have any blood in the sputum?
Well, it sounds like a normal cough to me, and I found no blood in his system.
For the vomit, do you notice what is the content, and can you estimate maybe how much he vomits every time?
Well, the content of the vomit is mainly what he ate before he vomits, and is around half a cup each time.
Okay. Do you notice when actually the symptoms become worsen or worse throughout the day?
Mm,
Maybe you can pinpoint any time.
um, I think it's around the same in the daytime as well as at night.
Oh, okay. Does the patient experience any fever or runny nose?
No,
Okay. Do you notice any eczema or rashes or maybe itchiness at your side?
no.
At your home, do you have any pets, maybe carpets or anything that is furry?
Mm, yeah, no.
Okay. May I know if there's anyone at home that smokes?
There's one. My husband smokes, but he only smokes outside the house.
Okay. Can I know if your son had any of the similar event happen before?
Yes, he had a few asthmatic episodes diagnosed when he was around 4 years old. After he had been hospitalized at Mossad with the same symptom, due to the same symptoms, and the triggers that we found out were cold weather and ice drinks.
Oh. Okay. About his you said that he has been diagnosed before and has been hospitalized. Can I know about the details about it?
Well, for now, this is the patient's fourth hospitalization. The first one is about 6 years before, when he was 4 years old due to the same, similar to the patient. But he was treated as that's how he was treated as newly diagnosed intermittent bronchial asthma, if I'm not mistaken, at the hospital. And the doctors prescribed him with MDI salbutamol PRN. The, the second hospitalization was when the patient was 7 years old due to what the doctor said called acute exacerbation of bronchial asthma. He was prescribed with MDI salbutamol PRN2, and the last admission was on last year. He was prescribed with MDI salbutamol, the blue colored one, and on follow-up at nearest clinic kesihatan. Other than that, there's no other hospitalization or surgery that he had gone through. Yeah, and even his immunization is has completed.
Oh, okay. So that's good. Okay, so about this medication, is there any other medication that he's on, or maybe you can tell more about the medication of asthmatic that he has now?
Oh well, he was prescribed with metered dose inhalers for his asthma, and he other than that, there's no other medications, and he uses his metered dose inhalers occasionally in the morning before going to school and at night before sleep.
Okay. So does he have any known allergies, maybe food or maybe other things around him, or maybe drugs allergies?
So far, he had no known allergies to food, medication, or through contact with animals or objects.
So about his birth, do you notice any important event before, during, and also after his birth?
Mm, Before his birth, it was quite uneventful. I was healthy at that time, and I do regularly go to checkups throughout my pregnancy. And he was born at full term at 38 weeks in hospital Sultan Haji Ahmad Shah via continuous vagina delivery, and he weighed around 3.1 kilogram. However, my son had neonatal jaundice for around 14 days, but UV light treatment was not indicated. Other than that, there was no postnatal complication.
Oh, okay. So how about his diet? Does he skips any meals, or maybe he eats unhealthy?
Well, he was breastfed and given formula milk since he was born, and weaned when he was around 6 months old. Um, so right now he's on like our regular usual diet with 3 times of heavy meal per day, and there's also he also snacks in between meal, children, and but he does eat his vegetables.
Okay, great. So if you compare about his development to other of his siblings, how can you describe his development and also his growth?
As compared to his siblings, I think it's around the same. Yeah, he is a standard 5 student and has a quite good average performance in academics. He also have like some quite number of friends and was able to socialize well.
Okay, that's good. Okay, is there any other of his siblings in the family, or maybe you or your husband that have a same problem or any medical issue?
Mm, his elder sister has asthma. Other than that, everyone is quite healthy. There's no other remarkable medical issues.
Oh, okay. So may I know if you or your family has traveled to anywhere recently?
No.
Okay, this is quite a personal question, but we need to assess it so that you can know furthermore about his condition. So may I know where do you live and also what do you do for your living?
Um, well, we live together with we live together, yeah, and with as a whole family with his 7 siblings, and we live in Kampung Teluk Ira, Semenur. Well, the house has adequate water and electric supply, and I am a housewife, and my husband works as a security guard at primary school.
Oh, okay. I think oh I think that's all for the role play. Okay, I'm sorry. Thank you, Ms. Putri, for answering my questions. Um, I think that's all for the role play.
See, can you summarize?
Okay. Can I have someone to present the slides? Because my internet is not that good.
No. I need you to summarize.
Oh, okay.
One.
So basically, this patient names Abdullah Hakimi bin Tajuddin. I'm sorry. Okay. Okay, Abdullah Hakimi bin Tajuddin, and his age is 10 years old. He comes to the emergency department because of the breathing difficulty for 1 day duration. And his mother said that he is well 6 hours before the admission, and the difficulty breathing is associated with also rapid breathing and productive cough with whitish sputum. So he also has post-static vomiting 4 times prior to the admission. He present less active than usual. His mother said that these symptoms occur after he had eaten ice cream 1 day before the symptoms. So and also he had an asthmatic episode diagnosed when he was 4 years old, and his mother said that the trigger symptoms are cold weather and also cold drinks. For his past medical history, this is his fourth hospitalization. His first was when he is 4 years old. It is treated as a newly diagnosed intermittent bronchial asthma and prescribed with MDI salbutamol when needed. And his second hospitalization is when he's 7 years old due to acute exacerbation of bronchial asthma and is prescribed with MDI salbutamol when needed. And his third hospitalization is when he is 9 years old, prescribed with MDI salbutamol and also follow up to clinic kesihatan. For his drug history, he's prescribed with metered dose inhaler and occasionally use it in the morning and also before going to school and also at night before he sleeps. There's no other known allergies. For his birth history, the antenatal and perinatal was uneventful, but his postnatal, the patient had neonatal jaundice for 14 days, but there's no UV light treatment indicated. For his nutritional history, he was breastfed and given formula milk when he was born and weaned when he was 6 months. The patient is currently in adult diet where he has 3 times heavy meal per day and snacking between the meals. He does eat vegetables. For his developmental history, his mother said that it is going well and appropriate, and he also complete his immunization history. His immunization, sorry. So family history, he is 6 out of 7 siblings, and he has an elder sister which is asthmatic, and for others there is no known medical issue. And for his social history, he lives with his parent and also 7 siblings in Kampung Teluk Ira Temeloh. His mother said that the house was adequate with water and electric supply. His mother is a housewife and his father works as a security guard at primary school. His father is a smoker and claimed that he only smokes outside the house. So that's the summary.
Hey, Shamimi? Yeah, you still insist. I need to give me your ability to retain the knowledge, not to read it. Okay? If you are asking the patient, either you have a very small notes, you write the most important points, not to repeat all. So if you are trying to summarize now, you need to tell me that this patient is a known patient of bronchial asthma, is a 10-year-old presented by acute exacerbation. Yes. Due to what?
Due to cold drink, cold, I would say cold food.
Okay, so due to cold exposure. Okay, this is your summarize, which is very important. Okay, so let us ask you now, what is bronchial asthma, Shamimi?
Bronchial asthma is occur when there is a trigger that is posed to the patient, and there is a constriction of the bronchial where make the patient difficult to breathe, and usually it is present with difficulty breathing, cough, and also wheezing.
So who can give us a more systematized definition? Noral Potri. So what is the definition of asthma?
The definition of asthma is asthma is one of the disorder, is one of the conditions that presents with wheezing as per triggers, and usually there's bronchoconstriction as well as excess production of mucus around the that causes airway obstruction.
Okay. didn't come to the definition of asthma. Anyone can answer? If you are coming to anything, try to concentrate on the definition. It will guide you. I mean, if I told you, if you open Nelson or any reference with you, you'll find him said that asthma is chronic. It is not acute, okay? Reversible, because the word reversible differentiates asthma from other airway disease characterized by. So you must come back and read this one. So it is chronic and reversible. And I know that it is reversible by peak expiratory flow rates. Okay, I will do it for any pulmonary function test, and I will give bronchodilator and repeat it. I will find increase, okay, in the peak expiratory flow rate between 15 and 20%. If it is another cases of chronic obstructive airway disease, it is not reversible. Okay, it is not irreversible, it is fixed one. So that's why it is reversible. Means the patient today exposed to cold will come to us with asthma. Tomorrow he exposed to cat will come with asthma. After that he has exercise induced asthma, he play a lot, so we'll got asthma. Good upper respiratory tract infection, he got asthma, got pneumonia. So I must know, number two, what is the trigger for asthma? Okay. So this will guide me. The definition are very important. Basic medical and increased secretion. All this can cause sometimes severe respiratory distress. Okay, that's why it is very important to know the definition, to know what is the trigger for asthma, because I will teach the family. Your responsibility is only to be a doctor. You must have an important social role. Prevent the attack again. Okay, can I see your slides, please? Sorry, I need to switch off the video many times because the internet inside the hospital is not so stable. Okay. You can start, please.
Okay, Sila. I will present about provisional and differential diagnosis for this patient. Okay, next. So for this provisional diagnosis in this patient is acute exacerbation of the bronchial asthma because of patient present with breathlessness that worsen at evening and night, and also it occur at the rest and associated with the rapid breathing, cough, and also post-tussive vomiting, and there is no fever. And the patient also have a positive family history when he has sister with asthma. And he also has exposure to triggers, which is the cold food. And he also have daytime and nocturnal symptom. And he also has history of the underlying bronchial asthma because of the previous hospitalization and also drug history for the asthma. Okay, next. And the differential diagnosis, the first differential diagnosis is pneumonia. Points for the pneumonia is rapid breathing and also productive cough. And points that against pneumonia is there is no fever, no runny nose, no sick contact, and also no travel history. And second is acute bronchitis. Points that suggest for the acute bronchitis is rapid breathing, and points against it is there is no whooping cough, no fever, and also runny nose. And thirdly is viral cough. Points for it is rapid breathing, and points against it there is no runny nose, sore throat, no barking cough, fever, and there is no hoarseness of voice. And lastly is acute epiglottis. The points that suggest it is rapid breathing and also cough. Points against it there is no hoarseness of voice, drooling of saliva and fever, and there is no difficulty to speak and swallow. Okay, so that's all from me.
I think for any patient with chronic cough, okay, I know that it is not the situation. We just, in our practice, we must suspect is it TB or not. Okay, because especially if the patient has chronic and repeated cough. So we must ask about loss of appetite, night sweating, exposure to someone with TB, or he got the vaccination or not. Also, some rare cases like cystic fibrosis and other which can cause bronchiectasis must be put in our minds. That is the group which is irreversible. Okay. Okay.
Bismillahirrahmanirrahim. I will present about the physical examination and investigation. For physical examination, for this slide is for the sign towards the asthma. General sign for toward the asthma, like upon the inspection, we can see the patient have a hyperinflated chest, high circle, where on the picture on the right, yeah, there is like a recession on the lower ribs, and sometimes if the asthma is come with the allergies, there sometimes patient have eczema or dry skin. On palpitation, and there is a decrease chest movement and decrease in vocal vibratus and increase in anterior posterior diameter of the chest of the patient. And in percussion, there is a hyperresonance to during percussion. Auscultation finding from the asthma patient, there is a diminished air entry, and there is a vesicular breathing with pollen expiratory phase. There is a generalized expiratory bronchi, and sometimes there is a crepitation on the auscultation. And there is a signs in acute as a patient, where the patient has sign of a tachypnea and there is a wheeze and bronchi during auscultation, hyperinflated chest, the using of accessory muscle because the patient have a difficulty in breathing, cyanosis, where the patient look bluish, drowsiness, and tachycardia. And from the cases, the positive finding that can be found in these cases. From the respiratory examination, on auscultation, there was a bronchi from the lower zone of the left lung, and there was a scattered capitation head over the left lung. And but in this case, there is no there is no we call from the generation there is not written there is the patient having difficulty to breathing or having what we call hydrocephalus, but based on the past visitation, there was a hydrocephalus, subconscious recession, rapid breathing, as well as bronchi and capitation of both lungs. And next is investigation. Investigation to diagnose asthma. The diagnosis of asthma can be made with if the history of the physical expression is suggestive asthma. Most investigation are for to assess severity or to assess response the response of the treatment. And some of the tests that can be made that must be made for the suspected asthma patient is the first is a lung function test. The first is a spirometry. Spirometry where we want to investigate the lung function of the patient. Where in the asthma patient there is a normal FVC and reduce of FEV1, and there is a reduce in FEV1 FVC ratio about decrease more 0.8. And the next lung function test is a peak flow meter. And lastly is exercise induced asthma. Other investigation, next investigation. Next investigation is imaging. Imaging must be made if we suspect other facial diagnosis like pneumonia, and when the treatment and we suspect the patient with asthma, when we give the treatment, the treatment is not respond, we can indicate we must do imaging to the chest X-ray to investigate other possible disease that can happen to the patient, and other investigation like allergy testing, skin prick test, where we want to see that if the patient have any allergy. And finally, for investigation is one which is on the chest X-ray. There is a perihilar haziness, especially on the left side of the lung, and there is no hyperinflated lungs. I think that's all for me.
Okay, so your presentation, please. It is the same it is the same sequence of our clinical practice. Okay, so that is the most important point. That we are coming to the patient, we are getting to see him generally, how is the patient like. Okay, he's in acute attack. But I hope you are presenting after that what is the difference between mild or moderate or severe or life-threatening attack. So I must be able to judge rapidly how is the severity of the disease. The investigation, we need to add that we have right side investigation. You can come back to the investigation. Yeah, this is a very important. The lung function test, which is the peak expiratory flow rate. Of course, this can be started from 5 years, not less than 5 years, so the patient can help us to do it. Okay, but there is another one, which is the pulse oximeter, consider an important investigation. Okay, because if the saturation less than 95, you must take care. Okay, the other thing, you need to add blood gas, arterial blood gas. So I used it to tell you it is all in your hands. Okay, all is in your hands. If you put this pulse oximeter, if you did this blood gas and peak expiratory flow rate, it is very important. It will guide us beside the other clinical points. Okay, good. Let us continue. The OSCE.
Okay, now we will proceed with the OSCE session, and it will be conducted by me, Muhammad Afiq Idham bin Ismail, metric number 1817741. Okay, so let's go to the first question. Okay, question 1. State the findings that you can see in the picture. So this is a picture of Harrison sulcus that you can see in patient with acute exacerbation of bronchial asthma. So the second question, we have stated that the diagnosis is acute exacerbation of bronchial asthma. State 3 clinical features to support your diagnosis. So clinical features basically combination of sign and symptoms. So if the patient is an asthmatic patient, so the most important features in this patient is the important triad one, which is the cough, shortness of breath, and also wheezing. And this is other sign and symptoms for the asthma. Okay, next question.
No, let them again comment on that nice picture. So now, what you can see now?
Recession.
Yeah, there is a hyperinflated chest. Okay, and there is intercostal, and it looks like also subcostal recession. And I don't know if it is also there is up in the trachea, is there any tracheal tug or suprasternal recession. It's very important. These signs, you must come up and comment on the mouse if it is present, if it's cyanosed or not. Because cyanosis is the end deterioration of severe respiratory distress. Okay. Okay, continue.
Okay, question number 2. Sophie, a 6-year-old Malay boy with underlying asthma, presented to emergency accident and emergency department with silent chest. So the first question is, what is the severity of the asthma? Okay, silent chest is actually one of the characteristics of life-threatening asthma. So the second question is, state 3 other signs that probably present in this patient in regards to the severity. So if the patient has life-threatening asthma, the patient may present with apnea, unable to speak, drowsiness and confused. The patient may also have poor respiratory effort, and the patient may have paradoxical thoracoabdominal movement. The patient also will present with cyanosis, bradycardia, and the peak expiratory flow rate is unable to perform in this patient. So the next question is, state 3 cardinal features that usually present in asthmatic patient, like what I have said before, cough, shortness of breath, and also wheezing.
So what's your colleague understand from silent chest now? Can anyone answer what is the silent chest?
classifies the life-threatening asthma?
Yes. What is, how can you prescribe it for me? Idham?
Basically, silent chest is when the lung continue to be tight. It like tight. So therefore, there is not enough air movement to produce wheeze, because in the earlier stage of asthma, there is wheezing. However, in this life-threatening asthma, because of the lung have been tightened, the air that move into the lung is not enough to produce the wheezing. Therefore, it is called as silent chest. No sound produced at all.
Yeah, you will find that the patient has like air hungry, he needs to go to respiration, but when you auscultate, remember that the asthma will go through many steps, just cough and recession, and after that you are going to hear like expiratory wheeze, okay? After that, if it is severe, it will be inspiratory and expiratory. And if it is more severe, you can listen to any wheezes. It doesn't mean the patient is improved. You must look for the patient as a whole. You will find his chest is hyperinflated and he looks like have air hungry and his heart rate are increased and he's cyanosed and you must take care about that. So silent chest is a bad sign. You mean you will find the chest like hyperinflated, but the air entry in and out is so poor and no wheezes. Okay, thank you. It is a good point. Continue.
Okay, this is actually a table for to determine either the acute exacerbation of asthma is mild, moderate, severe, or life-threatening. Okay, next.
Yeah, no. Come back.
No, okay, come back. Okay.
You must know this like your name, please. This is a very, very important slide. Now we are speaking about the severity of the attack. Listen to me. We have, for asthma, we must be able to define how is the course of the asthma. I mean, is it intermittent or persistent? And if it is persistent, it is mild or moderate or severe. But this one is speaking about the attack itself, which can be either mild or moderate or severe or life-threatening. And you must be able to define the patient if he came to you in the emergency department, how is the severity? And it looks very simple. As we speak before, breathlessness, but even the ability to talk. If someone has severe distress, you ask his name, he will say, my name is, and then good breath and another word like that. If you read Al-Fatiha like that, alert or not, what about his respiratory rate? Started to increase and then markedly increase, but here it will be poor effort, okay? It is very simple, even about the wheezes. We spoke about silent chest. The most important, which I told you, the FiO2 and the oxygen saturation, the pulse rate, and the most important also to do the peak expiratory flow rate. So please take care about early diagnosis of asthmatic patient, because if you intervene early, you can save him from intubation. If you are a bit late, intubation with asthma are very, very complicated issue, okay? Good. So please, you must revise the asthma from your pediatric protocol, which is an important book in your hands. Next.
Okay, the next question is question 3. What is the name of the device? So this device is aero chamber spacer. So the next question is, explain the steps to use this device. Okay, next slide. Okay, this is how to use aero chamber. The first thing that we need to do is we need to shake the inhaler first, and we need to remove the cap of the inhaler. After that, we should connect the inhaler with the mask spacer, and the mask spacer should fully cover the mouth and nose, and there should be no gap between that. After that, we need to press the inhaler to spray one puff of medication into it. And we need to ask the patient to hold for 20 seconds, count 10 valve flips. If valve flip does not function, count chest expansion for 10 times. Okay. Okay, next question. Okay, question number 4. Fahim, 4 years old Malay boy, presented to accident and emergency department with worsening shortness of breath and wheezing for 2 days duration. The first one, what is your provisional diagnosis? So wheezing, shortness of breath, worsening shortness of breath, 2 days duration, and therefore I believe that this patient has acute exacerbation of bronchial asthma. The second question is, state 3 other symptoms the patient may elicit to support your diagnosis. So the important triad, which is the chest tightness, cough, and also chest tightening, cough, and also wheezing. However, shortness of breath and also wheezing have been stated there. So we can say about chest tightness, cough, and also eczema, because eczema is one of the risk factor for the patients to exacerbate bronchial asthma. Okay, the last question is, state the pathophysiology of this current condition. So the pathophysiology of asthma, the first one is mucus hypersecretion. The next one is mucosal edema. And the last one is bronchial muscle spasm that will lead to the narrowing of the respiratory airway. Okay. So I think this is the last question for OSCE session.
For the treatment, you can go through it, please, but you must know that in year 3, you are not going to go deep for the treatment. You need to know the general lines, okay? So just remembering you that for asthma, as a chronic disease, we have 2 lines. The first line is the preventive line. Okay, how can I prevent the next attack? We spoke, we can just educate the family about how to prevent exposure to allergens like that. But the most important, there is many medication which we can start, like inhaled steroid, like Montoliocast, okay, and even now there is IgE. All this, how to prevent the recurrence. And this is based on GINA criteria, which is defining for you how severity is the patient asthma, and when you are able to de-escalate or escalate, okay? So you must go for GINA guidelines, how to increase or decrease, okay? But the most important to know that we have 2 pillars now. One is the preventive and one is the rescue one, okay? And all of these are available in your pediatric protocol and in your books in your hand also. Is it clear? Another slide you need to add, what is the asthma action plan? If I got our patient admitted to the hospital, before I can discharge any patient, I must write a clear action plan for him, okay? So you must come back and read about the asthma action plan, because it will help the patient to manage his asthma and prevent the next attack and what decisions he can take. Am I clear? So you need to add all this correction to your presentation, and you will send me at the end, inshallah. Okay? If it is good, it will help other colleagues sometimes to present it to them as examples. Do you have any question about asthma before we finish? We now finished 1 hour. We know that asthma is a chronic, reversible, obstructive airway disease that pathophysiology is blah, 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 okay? and the main management is like that. But the most important point for asthma is to define the course of the asthma. Is it intermittent or persistent? Is it mild or moderate or severe? Then what is the precipitating cause, like your colleague asked? And the most important, which must be forgotten during the examination, what other sign or symptoms of allergy? No one comment about the skin. And all of you know what is API, asthma predictive index. It needs to be, please make one question for that. What is asthma API, asthma predictive index? Okay, and it is very important to ask yourself if the patient got any other signs of allergy, which mainly eczema and dermatitis and rhinitis. This is a very famous triad. Asthma, rhinitis, and dermatitis, because it will guide me which medication I will use. Okay? That's fine. Do you need any question? Or we can start the second case?
Doctor, I want to ask one question. I have been reading about status asthmaticus. Is it the same with life-threatening asthma or not?
It can, status, I mean the attack is prolonged one. Okay, so with time, yes, it can be turned to life-threatening, but even if it is severe, it can be status. I mean the asthma is still going and it didn't respond to the initial treatment which you are giving, like nebulization, like that. So at that moment, we are upgrading our to give IV. Okay, if we are giving salbutamol inhalation, we can give it intravenous. If we are giving hydrocortisone oral, we can give also IV. If the patient doesn't improve, we have another line, like magnesium sulfate. You have that on the table of treatment of persistent or life-threatening asthma. Okay, it will be also need to give like magnesium sulfate, aminophylline, and at some moment we need to intubate the patient and put him on mechanical ventilator, which is not preferred. Try to do your best before you reach to this decision. Okay. Thank you. So Shamimi, you have a good team, Shamimi.
Yes, I'm grateful for them. Thank you guys.
Presenting with you. Please next time we use in Arabic to say العلم في الراس مش في الكراس. Means the knowledge must be in the brain, not on the book. Okay. Try to retain. Don't dependent on the other will be present for you, because really in our life you must be very alert, especially taking what it is, taking a history from the mother or from the family. It is good just to notice it, because you are not. It is not good to ask them, oh please, I like to ask you again what happens again, what that it may be not good unless you are a bit elder like me. Okay, so it is good to concentrate and to try to document. And I'm just warning you about the importance of ability to make summary. I mean by the summary, inshallah, you are starting to count 1,000 a day, and then you will find yourself in the emergency department. We are preparing you. We are trying to give you every day, every meeting, every teaching, every seminar, a new clinical sense. So you can, inshallah, be like a gold. Whenever we put you, you will, inshallah, have a high value. Okay, that is the issue. Try to build your ability for concentration, for to be systematized, for differential diagnosis. Every day we are going to give you extra and extra points. Okay, so please, to summary is an important. I mean, it may be at the end you have 50 patients in the world and you need to endorse. If you are going to read all the notes will not finish. And the other colleague also. So can I give the most important, which I cannot omit by any way, okay, and give it in a good. As I told you, you must be able to tell this patient non-asthmatic, 10-year-old, has acute exacerbation of bronchial asthma. Okay, due to cold exposure, he has history of admission to the hospital 4 times before, but he didn't admit it to ICU. He has eczema or rhinitis or not, because it different. It will help me for taking extra line. His family history of asthma is like that, so I know it is maybe genetic or intrinsic one, not extrinsic. It is very important. Every word from your summary must give extra way for the sentences, okay? He responded initially to the nebulization or to the, like that, his peak expiratory flow rate improved from lab to lab. This is my point, okay? Okay, second presentation.
Next, so the next case, I am Siti Aisha, and I'll be in charge in the role play together with Shasha Samimi as the mother of the patient. Okay. Okay, start. Okay. So, Assalamualaikum.
Aisha.
Aisha.
Who
Can we?
Aisha? Amimi?
Yes. Aisha and Shasha. Okay.
Who?
Okay.
Aisha is the doctor?
Aisha is the, I am the.
Okay.
Okay. Okay. Okay. Assalamualaikum. Assalamualaikum, Puan. I am Aisha, a third year medical student, which in charge in assisting you today. How can I help you?
Waalaikumsalam. My son is having rashes and fever for a few days already.
Rashes and fever. Before I start, before I proceed with other questions, may I know your child's name and also his age?
My son is Adrian, 4 years and 1 month old.
Okay. Okay. So you mentioned that he had rash. So when did you first notice when he had the rash?
The rash about 4 days ago.
4 days ago. Okay. So can you tell me the location of the rash?
The rash started from the side, and then after that it went spread to all over his body.
The thigh and also spread over his body. So did the rash develop gradually or suddenly?
Gradually.
Gradually. Okay. Did you notice if your son is having itchiness because of the rash?
I think no, because I do not see his scratching anywhere.
So no itchiness. Okay. Did you do anything to reduce the rash?
On the next day, I brought him to a private clinic, and they gave us a syrup paracetamol and also a lotion.
So you receive a syrup paracetamol and also lotion. So so did the rash resolve upon taking the medication?
No.
So the rash is okay. And okay, you also mentioned that Eden had fever, right? So when did you notice that he had fever?
In the evening, a day after we went to the clinic, he complained to me that he feels like he's having fever.
So it was 2 days after having the rash. Okay. So did you happen to record the temperature?
Yes, it was 37.8.
37. Okay. So did you notice if his fever, his temperature fall within these 2 days? No. Okay. So, did he experience any chills or rigor together with the fever?
The fever was persistent, but there's no case or I don't.
So also, is there any cough or runny nose?
No.
Okay. Did your son feel any lethargy, or does it affect his activity?
Yes, he complained to me that he felt tired and he was not as active as usual.
So he does. Okay, lethargy and so. Were there any other symptoms associated with the fever, except that I mentioned before?
Yes, he's also having diarrhea and vomiting.
Diarrhea and vomiting. So when did you notice that he had diarrhea and also vomiting?
On the same day that he started to develop the fever.
On this, okay. Can you tell the amount of the diarrhea and also the vomit?
The amount, I think it's about 1 cup for each episode.
1 cup. 1 cup for the diarrhea and also the vomiting.
He's having diarrhea for about 4 times, but only vomit for 1.
Oh, 4 times. So, did you notice any color changes in the stool and also the vomit?
For the stool, it was watery and yellowish brown in color. And for the vomiting, no, it was just food particles in it.
So there's no color changes in okay. Did you notice any changes of his appearance? Dry lips, dry eyes?
I think no.
No, so okay. No. So did he experience any abdominal pain or headache?
No.
Okay. Before this, do your family has eaten any outside food?
No, we do not go eat outside because of the people.
Sorry, did you so did you notice any swelling at any part of his body or
No, there's no swelling.
so any loss of appetite or loss of weight?
No.
Did he have any difficulty in breathing?
Also no.
No. So did he have any associated symptoms like night sweat, joint pain, muscle pain? No. Okay. Did he have any history contact of with sick people?
No.
No. So about his urination, does he urinate normally?
Yes, it was normal because he did not complain anything.
Yes, okay. So, did he has any past medical history or surgical history?
This is the second time to be in the hospital. The first was 2 years ago. He was admitted because of the atypical pneumonia. But he's never undergone any surgery.
So uh, 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 other than the syrup, paracetamol and also the lotion prescribed by the doctor, did he take any medication? Other medication? Okay, no. Okay. So did he have any drug allergy or food allergy?
No.
Okay. So now did your son follow all the immunization?
Yes, we do follow the study.
Okay. So regarding your birth, okay. Uh, did he have on a normal birth or did any complication happen during his birth?
No, everything was normal and fine.
Okay. So compared compared to other children or his other siblings, if you are, did you notice any delay in his development?
No, it was normal.
It was not okay. So for his diet, did he has a healthy diet or having any problem in his diet where if whether if he's a picky eater?
No, he just ate whatever given to him.
Okay. So for your family, does he have any other siblings in
Yes, he has a 12-year-old sister.
12 years? So he's the youngest one.
Yes.
Okay. So do you and your husband work?
Yes, I'm a clerk.
Okay. So is there any family member is there any family member that have is there any family member that have other disease?
No.
No. So you so all of your family members are healthy. Okay. So okay. If you don't mind, I would like to ask where do you live? Sorry, can you repeat
I live
again?
in Selda Bukit.
Oh, so Bukit Go. So can I ask if that area is common for dengue?
Yes, not long ago there was fogging in our area because of one of our neighbor being diagnosed with dengue.
Yeah. So did you travel anywhere before this or did any activities outside?
No, we just stay at home.
Okay. So can I know the environment of your house, whether the water supply is clean or anything?
No, everything is okay.
Everything is okay. So did you have any problems of rodent infestation at home?
No,
No. Okay. So okay. This question might be sensitive to you, but can I ask if any if you or your husband smoke?
no, we don't smoke.
So we don't. Okay. So okay. Is there any clinic near to your house area?
There is one clinic kesihatan Bukit Go, about 10 minutes away from our house.
Clinic kesihatan. Okay. So I think that is all. So is there anything more that you would like to mention or any concern that you would like to address about your science condition?
No.
Okay, so everything is done. Okay, so thank you very much for your time. So I think that is all that I would like to ask. So and next I will proceed with the physical examination. Okay. So
No,
so
proceed with your discussion.
discussion.
Can you
Doctor,
can you
for
summarize?
the summarize. Okay. So for the summary of my case, so my patient is ED, a 4 years old, 4 years 1 month old, with no underlying disease, presented with 4 days of rash, and also followed by 2 days of 2 days of fever. So regarding the rash, the mother stated that he had the rash all started from his thigh and then spread to all over his body, and then they also went to clinic and was prescribed with syrup paracetamol and also a lotion. However, the rash was not resolved upon the medication, and the next day after they went to the clinic, he suddenly developed fever, which her mother stated that the temperature was 37.8, and then the fever was not associated with was persistent but not associated with chills and rigor, and then his mother also stated that AD was lethargic and not active as usual. So and also the fever was also associated with diarrhea and also vomiting 1 day prior to the admission. So besides that, it was also stated that they live in Felda Bukit Go, which is known to be a prone dengue area, and there was history of his neighbor diagnosed with dengue fever recently. Other
So what's your
history,
work?
okay, other history were unremarkable.
What is your working then?
Diagnosis? Dengue fever with warning signs, since he had diarrhea which occur more than 3 times, and also vomiting and lethargy.
So what is the warning signs? Do you know?
Other warning signs. So
Yes.
other warning signs beside besides lethargy, persistent vomiting, persistent diarrhea, it should be the intense abdominal pain, and then there could be presentation of ascites and also hepatomegaly.
Who can systematically answer the question? What is the warning sign? Do we know?
Warning signs. Is it the
Yes. I need to complete your answer.
warning signs include persistent vomiting, persistent diarrhea, and then intense abdominal pain, presence of ascites, and then hepatomegaly.
What else?
Mucosal bleed.
Oh, mucosal bleeding.
What else?
Or lethargy.
An important diagnostic test too.
The lab, the hematocrit, and the platelet count.
Yes, very important. We call it warning signs, but it contains even some from symptoms, some from clinical and some from the investigation. It's very important. The child have concentrated, okay, which I mean increase hematocrit or platelet. So, okay. So now, Aisha?
Yes.
How many types of dengue you told us now that the patient has dengue with? Is there any other types other than dengue?
Yes, there is dengue hemorrhagic fever and also dengue shock syndrome. So
and there is simple dengue.
Sorry, doctor.
Okay, we have simple one without neither warning sign or
dengue with or without warning sign.
Yeah, I mean we have simple dengue, we have dengue with warning sign, we have complicated one, which can be either hemorrhagic or shock.
Shock syndrome, okay.
Yeah. So, Dr. Aisha Humaira, now how many strain of dengue do we have? Aisha Humaira?
4.
4. Okay, if someone got infection with the first strain, he is immune against the others or not?
Not.
Very important knowledge. The internet here are very difficult. Okay, so the most important point to teach the family that we have many strain. So still the child, if you didn't take care, he can get another dengue, but another strain, okay, which can be more aggressive. So because some families said, oh, okay, we got dengue now, we are immunized, let us go and run and play with mosquito. It is very important, okay? As I told you, teaching the family is one of our priority to have a community which is educated about the disease and the early detection and what is the complication and how it can happen. It is a very important. Health education, even from Islamic point of view, يعني يرفع الله الذين آمنوا منكم والذين أوتوا العلم. فالعلم knowledge and transfer this knowledge to the other is one of the Islamic principles. Okay. The other thing now which we are going to ask who didn't share with us today, Adham?
Yes, doctor.
I would like to ask you what is the management of dengue?
Management of the dengue, the first thing that we need to do is we need to classify the severity of the dengue first.
Okay. Then?
And after that, we need to do the disease monitoring for
I
the
need
dengue.
general lines. Yeah, very good. So I need what severity, and then I need close monitoring according to the severity. Maybe in the ward, it may be in high dependency, it may be in ICU, according to the severity. Very good. What else?
The next one, because we know in dengue patient, usually the patient will have dehydration. So we need to manage the fluid.
Good. This is a very important. We need judicious managing the fluid. If you need to give, give. If you need to give a small amount, don't give big amount, because either dehydration or overhydration, both are harmful and can precipitate for more severe. Okay, that's good. That's why to know our priority, because dengue is a disease, number one, preventable, we are trying to prevent. Number two, it is manageable if we are taking care about. It has no specific treatment. Some study now start to give like antiviral, but it is not yet good worldwide acceptance yet. But I think in India and the Philippines, they started to use some antiviral as a trial for dengue, but until now we are treating him symptomatically, and it works. Okay, that's good. Okay, you can present your slides.
Okay. So so for the differential diagnosis, one is chikungunya, which the point suggestive for this that in chikungunya it has fever, rash, and malaise. But points against it that there is no joint pain, no headache, and also no conjunctivitis. So the next differential diagnosis is acute gastroenteritis, which the point suggests for this diagnosis is that this patient has fever, diarrhea, vomiting, and lethargy. However, the points against this is there is no abdominal pain, headache, joint pain, and also no history of eating outside food. Next is malaria. So the point suggests for this diagnosis that the patient has fever, malaise, vomiting, and also diarrhea. But the points against it is that the patient does not live in an endemic area of malaria, and also there is no headache, joint pain, abdominal pain, tachycardia, tachypnea, chills, sweating, and also hepatosplenomegaly. So next, differential diagnosis could be typhoid fever. So the points that suggest this is that patient have fever and also rash, but and also however the points against it is that the patient is not does not live in an endemic area of typhoid fever, and also there's no presence of abdominal pain, chills, hepatosplenomegaly. And the last one will be leptospirosis. So the points suggest for this diagnosis fever, diarrhea, and also vomiting. However, the points against this diagnosis is that there is no rodent infestation, no recent water activity, no rigors, headache, muscle pain, and also conjunctival suffusion. Okay. So this is how to differentiate the clinical features between the Zika virus infection, dengue, and also chikungunya. For the Zika infection, the most prominent clinical features is that is the rash and also conjunctivitis. As for the dengue, it was the fever, and it is the fever, and however the other symptoms less prominent. Okay, for it can present but less prominent. So in chikungunya, the prominent symptoms are the fever, and also the presence of arthralgia and also the arthritis. Okay, so that's all for me.
Okay, Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. My name is Nur Ainadia, and I'll be presenting on the phases and clinical manifestation of dengue. So how do we classify the dengue virus infection? We can classify it into asymptomatic and symptomatic, where actually majority of patients are asymptomatic, almost 50 to 90% of patients infected with dengue is asymptomatic. However, they can still present with symptoms where it ranges from mild dengue fever to undifferentiated fever and even to severe dengue, where infants have a higher risk in the pediatric age group to develop severe dengue. Okay, so next. Okay, so like I said, majority are asymptomatic, and if they're non-specific febrile illness, it's usually in the young children with primary dengue infection, where the incubation period can last between 5 to 7 days. Okay, and usually the illness begins abruptly, which is suddenly, and it can evolve within 3 distinct phases, which is febrile, critical, and recovery. So let's go through each phases. So in the febrile phase, next, okay. So in the febrile phase, the patient can suddenly develop high-grade fever that lasts to 2 to 7 days. So in our patient, they develop a sudden high-grade fever at 38.7 Celsius. And then they can also have other clinical manifestation where it's usually associated with facial flushing, skin erythema, as we can see in our patient. There is arthralgia, myalgia, headache. We can even have photophobia, rubelliform exanthema. And they can also, since dengue is a virus, there can also be other systemic viromic symptoms. So we can have the severe headache, retroorbital pain. We can have diffuse body pain, sore throat, injected pharynx, conjunctival infection. The patient can also have altered taste sensation, anorexia, nausea, vomiting, even enlarged and tender liver. And they can also actually present with mild hemorrhagic symptoms. So we can have petechiae, mucosal membrane bleeding, easy bruising, bleeding at venipuncture sites. So as you can see, most of these are mild. So massive bleeding is usually rare. And also, as you can see from the clinical features in this phase, it's usually non-specific, so it can mimic any type of disease, and that's why it is actually difficult to recognize dengue in the early stage. However, so as you can see from the picture, this is a positive tourniquet test, so which helps us and also increase the probability that this is dengue. Okay, so for the next phase is the critical phase. It can also be known as the defervescence phase. So it's usually at about day 3 or day 5 of the illness, but it can also last to day 8, and it usually lasts between 24 to 48 hours. So this is usually where the symptoms are worse. So what is defervescence? It is basically where this temperature suddenly drops to about 37.5 to 38 degrees Celsius after 72 hours of fever. So for example, our patient before is 38.7. So if the patient suddenly drops the fever to 37.5, that's when he's going through this phase. However, he is not. Okay, so for this phase, we can differentiate it. So they can either have minimal or no plasma leakage occur. So that's when they have no without warning signs. But they can also have the critical volume or plasma leakage occur. And this is when they present with the warning signs or even can present with shock. And actually, this is usually due to the increased vascular permeability. And many patients actually recover spontaneously in this phase, or even after a short period of fluid therapy, since most are usually in the febrile phase. Okay, and then next, this is the WHO dengue classification where, okay, so as you can see from there, with or without warning sign, if it proceeds to severe dengue due to increased vascular permeability, it's usually can present with severe plasma leakage, severe hemorrhage, and also severe organ impairment. Okay, and I believe this will be for, so the organ impairment usually includes the liver, the CNS, and also the heart. Okay, next. Okay, next. So my friend shared an acronym on how to easily remember the warning signs. So we can remember CRAMPLE. So C for clinical fluid accumulation. So there's ascites and also pleural effusion. R for restlessness or lethargy. And then A, abdominal pain, so tenderness. So it's usually continuous and severe as the warning sign. And then M, mucosal bleed. So it can range from the nose, from the gums, from your conjunctiva, vagina, GI, respiratory and urinary tract. And also persistent vomiting and diarrhea, as we see in a patient, the persistent diarrhea almost 4 times per day. And then we can also have liver enlargement, which is more than 2 centimeter. And also don't forget about the lab results where the hematocrit will increase and there will be a decrease in platelet. Okay, so the last phase is the recovery phase, which can also be known as the convalescent phase. So this is usually after the onset of the plasma leakage, and it occurs 48 to 72 hours after the critical phase. So once the patient survives the critical phase, usually the plasma leakage stops. So that's when we have gradual reabsorption of the extravascular component. So this is when we can see our patient improvement. So their well-being improves, their appetite returns, because before they lost appetite, now they have their appetite back. Now the gastrointestinal symptoms starts to disappear, so the nausea, vomiting, the diarrhea, and then diuresis starts, and actually the hemodynamic and hematocrit stabilizes, and we can also somehow present with cardiac manifestation, which is actually common, like bradycardia and hypertension. And this is also the phase where the white blood cell count recovers, then only the platelet count recovers. Okay. However, it is important to note that this phase is usually marked by the Herman's rash, also known as the Isles of White in the Sea of Red. So it's basically an erythematous or particular rash with small areas of normal skin over the extremities. So if you can see, like the whole skin is red and then there's suddenly like spots of white. So that's how you can notice, okay, the patient is in recovery phase. And also, since we know fluid therapy is one of the important management for dengue patients, excessive fluid administration can lead to respiratory distress due to the massive pleural effusion and also ascites if we give excessive intravenous fluid. Okay, and then next. Okay, so this is the summary of clinical features, more like complication. So in febrile, we can have the patient for dehydration, high fever, and then critical, as you can see, shock, hemorrhage, organ impairment, and recovery, fluid overload. And lastly, to help us notice the diagnosis, so next slide. Okay, this is taken from the CPG last year. 2020, the updated one. So how, since dengue is difficult to diagnose, since the symptoms are usually non-specific, how we can make a criteria for the provisional diagnosis is first, live in or travel to dengue endemic area, so we can see in our patient, and then have fever also in our patient, and they also presented with vomiting, rash, so and the warning sign of diarrhea. So we had like 5 signs of our patient, uh, of our patient for our provisional diagnosis, and that's how we come up with it. And that's all from me. Thank you.
Yes, go ahead.
Okay. Okay, so next I will proceed with complications, investigations, and management. Can you hear me?
Yes, we can, Shasha.
Okay, so for the complications, first of all is the dengue hemorrhagic fever, which listed in the WHO. The criteria need to be fulfilled for dengue hemorrhagic fever, which are any fever or recent history of fever lasting for about 2 to 7 days, any hemorrhagic manifestation, thrombocytopenia with the platelet count is less than 100,000 per microliter, and also any evidence of plasma leakage due to increase in the vascular permeability. For second one is the dengue shock syndrome, which criteria from the WHO for dengue shock syndrome are they need to fulfill all the dengue hemorrhagic fever criteria, and also with other criteria such as hypotension, tachycardia, narrow pulse pressure, and also sport activities. Okay, next. Other complications. Other complications may include the hypovolemia, which are very life-threatening. is the decrease of hematocrit and white pulse pressure. Next is the fluid and electrolyte loss, hypopyrexia, and also febrile convulsion. This is a very frequent complication in infants and also young children. And lastly, for the complications, is the epistaxis, petechiae, and purpuric lesion. This is uncommon but may occur at any stage that has been mentioned before. Next. For the investigation, there are types of investigation, which are the disease monitoring lab test and also the diagnostic test. For the lab test, usually we do the full blood count and also the liver function test. While for the diagnostic test, there are the dengue serology test, virus isolation, okay, and next, for the management, first of all, during the first encounter to the patients, we need to establish whether these patients really have the dengue or not. And then after that, we need to determine the phases of the dengue and recognize any warning signs of presence of the severe dengue. Patients without any warning signs, there is no need of hospitalization. We can educate the caregiver regarding the fever control and also avoid using NSAID. Also, we can give the dengue information or home safe card that emphasize the danger or warning signs of dengue to the caregivers, and patients that not being hospitalized need a daily clinical or lab assessment until the danger period has passed. Next. For indications for hospitalization, there should be any presence of warning signs that has been mentioned before by Aisha. Infant, if the patient is an infant or children with any comorbid factors such as the diabetes mellitus, renal failure, or obesity, and also because of the social factors like the patients live far from the health facilities or having any transport problems. The three major priorities in the critical phase are the replacement of plasma loss, early recognition and treatment of the hemorrhage, and also prevention of any fluid overload. Next. For the fluid therapy, there are two parts, which are the initial and rapid bolus. For patients with any warning sign but not yet in shock, fluid boluses is not necessary to be given. And hemodynamic state should be considered, should be used in considering intravenous fluid, not the hematocrit count. Okay. For discharge, if the patient is having dengue hemorrhagic fever or dengue shock syndrome, they can be discharged if there are febrile for 24 hours without any antipyretic. They have a good appetite, adequate urine output, a stable hematocrit level, at least 48 hours since the recovery from the shock. There is no respiratory distress and the platelet count is more than 50,000 cells per microliter. I think that's all.
Hello. Okay, I will be thinking about the first key. Okay, first question. Uh, okay, there is a boy who presented with fever, headache, and rashes, and based on the pictures we provided, describe the rashes, and as we have learned from the presentation, we can see the rashes is an islet of white in the sea or of red. And the second question is what is your diagnosis and which phase of the disease did the rash appear? Uh, it is appear in dengue fever in the recovery phases, in the recovery phase. And next question is the what are the other phase of dengue fever and explain in relation to the symptom and laboratory changes. And we have learned it before by the presentation by the neuro Ain. The next slide. Next again. This figure where there is a three phase in the dengue fever, and this figure is very important because each phase will lead to different potential clinical issues, and it will affect the management and treatment of the patient. And also we can see that in a febrile phase in serology and virology, it is there is an increase in viremia, therefore, and a virus study of PCR, which usually not offered, or NS NS1 uh, anti-gluten test can be done, and it will show a positive, which means the patient may have dengue fever. Next question. Next question is about a child with presented with fever, vomiting, and headache for the past 2 days, and NS1 and IgM for dengue are positive, and the platelet count is 60 times 103 per liter. First question is state the dengue virus family. Second is the serotypes and the vector. We also have discussed this before. Regarding the virus family is belong to the Flaviviridae, and for the serotypes, there are four serotypes, which is fourth serotype of dengue, and the vector is the Aedes mutatus, such as the Aedes aegypti. Second question is about what is the warning sign. We also have discussed this before, and by Nurul Ain have given us acronym for easy remember, which is the SCRAMPLE. And lastly is what is the technique site and how to perform it. Uh, Next is about the answer. Next slide. Uh, this is a technique test. It is usually done in during the febrile phase, the first phase of the dengue fever, to help in our diagnosis to differentiate dengue with other disease. Which this test is usually is to determine the capillary fragility and or the hemorrhagic tendency. And how it is done is first we take the patient's blood pressure and record it. For example, if we got is 170, and then we will inflate the curve to a point midway between the SBP and DBP, and then we maintain it for 5 minutes, and then after that we will reduce it and wait for 2 minutes, and then we will count the petechial below the anticubital fossa. It is shown positive, it is 10 or more petechial per 1 square inch. The third question is the next question is about a 10-year-old boy was admitted to the hospital with a 4-day history of high fever, abdominal pain, persistent vomiting, and a 2-day history of epistaxis and hematemesis. He was diagnosed by doctor with a severe dengue. First question is, what is the criteria of severe dengue? The criteria for severe dengue, as we know, is there is 3, which is first, which depend on the severity of the plasma leakage, which may lead to shock and fluid accumulation. With respiratory distress, the patient may present with uh, difficulty in breathing, high breathing rates. And second criteria is in severity of the bleeding, which will evaluated by the pediatrician itself. And lastly is the severity of the organ involvement, which such as if there is an in liver involvement, there is will increase in transaminase. If there is an CNS involvement, there is an impaired consciousness, or the patient may present with seizures and others organ involvement such as heart and such as heart. And next is list the risk factor for severe dengue. There is some uh, risk factor for severe dengue. First is lethargy, abdominal pain, bleeding tendencies, hepatomegaly, hemoconcentration of more than 22% of baseline, and thrombocytopenia of less than 100,000 per microliter. And next question is about the criteria admission of children with dengue infection that has been presented by Shasha. And first of all, if the patient is infant or with age of less than 12 months, the patient have warning signs, or the patient come with feature of severe dengue, or present with comorbidity such as diabetes, or maybe due based on the social factor of the patient, which is difficulty for outpatient monitoring. Next. Here is the answer. And the lastly is the outline management of compensating dengue shock in children. As Yasha have mentioned, in managing a patient with dengue, first we must know about the establish if the patient has dengue, and then determine the phases of illness, and then determine whether the patient need and replacement of plasma losses, and then in the early recognition and treatment of the hemorrhage, and in the prevention of fluid overload. I think you can see in the table, but and here is the continuous reassessment of the hemodynamic status of this patient after we giving fluid. And then we must reduce the fluid if the patient is recovering. I think that's all.
Okay. So let us now concentrate. Of course, dengue fever is most common endemic disease, and we must know the knowledge from A to Z. Okay. Can we just come back to the differential diagnosis? So today we are already touched two important points. The first one is the asthma, which we know now how is the importance, okay, to even inside the diagnosis to know the details. Is it severe or mild or moderate like that? What about the attack? It is life-threatening or other? And we are able to even define the severity. Is it silent chest or not? This is a very important point inside the diagnosis itself. And we got an important lesson, what can be also differential diagnosis. It is like bronchitis or pneumonia with spasm. It can be other like foreign body, or it can be many differential diagnosis speak. So we got an important lesson about the wheezes. Wheezes means I can hear by my ear, but if I put my stethoscope, its name is bronchi. Okay, so it is very important. Second one is the fever. Okay, we can come to the first slide. To the previous one, to the previous slide. So also for fever, we need to work our mind just to differentiate the fever. Either it is fever with rash or fever without rash. Okay, it is very important it will guide us, okay, about the type of rash. So if we got any like dengue cells, okay, which started to see some few cases like herpes simplex, varicella zoster, or chickenpox, or like that. So we must be able to define if I have fever and temperature, it is dengue fever inside it, but it has its characteristic, but it can be other viral infection. Don't miss it, especially if you have some patient who is anti-vaccine. Okay, your colleague here concentrate about the chikungunya, which is an important viral, looks slightly severe, but it is not so common like dengue. Okay, the acute gastroenteritis, it means now if the patient got dengue fever, he can get this type of gastroenteritis known as parenteral diarrhea or parenteral gastroenteritis. Okay, it means as a part of systemic disease. So take care even if you are discussing a case of gastroenteritis to say is it enteral or parenteral. I mean by parenteral, it is a part of systemic disease which can be like otitis media, like UTI, like dengue fever. So it is very important. What is the clue for malaria? Yeah, I will ask someone to answer. Who can answer? I have now your names in front of me. Important point to rule out malaria is
The stages.
sorry.
The stages.
Okay, so here is the type of the fever, which occur as, which has its own spike quadri. Okay, it occur as spikes and the gut arrest. It is very important. What else? when the parasite got and make destruction of the cell, it can cause also jaundice and pallor. Okay, it is very important. And the issue is there that mosquito which can cause the malaria or not. Okay, and don't forget that malaria are very famous with sweating and like that during the attack. Okay, so the quotidian fever, I will ask one of you just to prepare different type of fever beside this slide to guide us how to understand. Like this malaria has quotidian fever. This typhoid, which is the next one, it has like step ladder. It starts by 35, 37.5, 38, 8.5, 39, until 34. So it is step ladder, and it is very famous with bradycardia. You will find the patient, in spite any one of us, if good fever, he will start to be tachy. But this patient is still, his heart rate is not increasing. And of course, your colleagues speak about the rash, like rose spot. Leptospirosis also is available in our country, so we must know what is the point with the leptospirosis. Muhammad Zulfarhan,
Yes, sir.
what is the point for leptospirosis?
Leptospirosis point is high grade fever and what we call this
Let us start from the history. From the history. What is the clue from the history?
High grade fever, fever with chills and vigor, and then there is a history of the coughing blood.
Who can answer an important point in the history? Is that
Doctor, for
yes.
leptospirosis, is it the recent water activity is the most crucial part to diagnose?
Recent water activity and exposure to ticus.
Yes, rodent.
Yes, it is very important. Okay, so you must ask about that. She will guide us. What else in the clinical side? Always, when try to divide your answer regarding by history, clinical investigation, and clinical examination and investigation also. So by clinical, what is important with the leptospirosis? If you look to the eye, what you will find? Conjunctivitis. Yes, so it is very important. If you found any conjunctivitis, you must take care, okay? Also, there is transaminitis, so you can find liver tenderness and abnormal liver enzymes. That's to mean I need you to work your brain, to put a baseline for your thinking. As if we are now sitting 10 or 11 on that session. Maybe all of us are human beings, but there is male and female, there is, everyone has its own characteristic. You will find the disease with time, it is like that. You need to specify who is this by history, clinical examination, and investigation to come to the diagnosis. Because to speak about fever and rash, you will find a very, very, very wide one. Okay, like Kawasaki disease. Kawasaki disease can also fever and rash, yes? What is the point for Kawasaki disease? Potri? For Kawasaki.
Kawasaki disease.
Yeah, he is, has also fever and what other? Who can answer? What is the criteria for diagnosis of Kawasaki?
Red and swollen tongue.
Is it cardiac manifestation?
So that is the issue. We have something, we don't have a complete thing. So you must read what is the full criteria for diagnosis the Kawasaki. Yes. Just a minute. Yes. Yes. No, I have to just teach you.
For the printer, I have questions on what we
Fruit any brain after
okay, I'll just write that down. So I just want to look for any anomalies. So sorry.
Is okay? Sorry? Alhamdulillah. Sorry. I may send you from the other groups. They presented a good presentation about Kawasaki. So the differential diagnosis for fever and rash is very wide. Okay, even sometimes it can come if you are dividing it like infectious, and this is another advice, try to divide in your brain the pathology, which can be infection, which can be autoimmune. We have here like autoimmune, okay? This case of Kawasaki, because not yet established, they are thinking autoimmune, which responded to IVIG. It can be even some cases of rheumatoid arthritis, which is known as chronic arthritis of the children, which also sometimes come with fever and rash. So it is very wide, okay? Even leukemia and the malignancy sometimes presented by rash and sometimes fever and sometimes arthritis. So it is very important to be thinking. And that is the days which will count with you. Today you see this case. After that you see this case. So with time you must build your knowledge, please, okay? With the same. Any problem? We have now a very nice book from Nelson itself, which is known as symptom-based diagnosis. Really, I was thinking to send it to you, but I found it may be a bit detailed for you, unless someone of you are able to just make to do that for you, inshallah. Okay? So try to build your knowledge and try to have a clinical sense. Try to be systematized, start by the history and then the clinical examination and then the investigation, which are concentrating what is the main diagnosis and what is the possible other diagnosis. Okay. Thank you. I hope, inshallah, next time you are prepared better than that. I will give the first presenter, which is Shamimi 6.5. And I will give Aisha or Shasha. Who is, I'm confused between the two names. Who is the doctor? Aisha?
Aisha.
We'll go to 7, okay? So we have 6.5. Please just document it and send it to the science officer. Thank you and see you inshallah soon. Don't forget to make correction for your presentation. Assalamu alaikum wa rahmatullah.
Doctor.
Yes.
Excuse me, doctor, just one question. Regarding the asthma presentation, we actually found the action plan from the CPG Malaysia. However, the action plan for asthma in children in CPG Malaysia is in Malay. So is it fine if you just put it?
You mean the asthma action plan?
Yes, the asthma action plan.
Do you need to teach me some Malay? It's okay. It's a good point from your side, but if you write the internet, you will find asthma action plan by English. Even
We found English ones, but it's for Malaysia. It's in the adult asthma action plan.
No issue. Just add it as simple, or try to just transfer it. Your mind must be able to compensate for medical. If you are speaking as a medical, you are going to present it as a pure English. If you are speaking with the patient, yes, you need it by English, by Malay.
So we just
So
put both.
put a simple transmission for the educational issue. Okay. Anyone has any concern or question?
Doctor, I have a question. So, in the CPG, it mentioned that DHF is not a part of the classification for dengue anymore. So, do we actually still use it though?
What is this? Sorry, again?
The dengue hemorrhagic fever, they said
Yes.
it's not WHO, and also the CPG Malaysia doesn't classify it under like the types of dengue fever, like the classification, but do we still use it in like our practice?
Clinically, yes. It means there is some viral hemorrhagic disease. They are not put a dengue as a viral hemorrhagic disease, but it can cause sometimes hemorrhage. Okay, this is a bit different. We have in our life, we see a lot of viruses like Ebola virus before it is very severe. And so they need to say it is just like not simple, not uncommon, okay, complication, which even responded to simple adjustment. So still one of the complication is hemorrhage. Whatever you just remove it from the upper title and put it down, no issue. We must consider that one. Okay, but take care. Don't miss follow up for the patient. I mean, if the patient has dengue fever, usually if it is simple, we will see his vital signs like every hours, which is the routine for the nurses. But if he has a septic or starting a manifestation of bleeding, which really we saw it very real and we see it very simple, you must document for the staff. Number one, you must do a recurrent round for the patient. Number two, you must ask, please, vital sign every 1 hour, like that. You must be able to define according to the severity, or if you need to repeat it earlier or later than that. So your order must be clear for the staff, auxiliary staff with you, nurses and other, and for yourself also. You need to see the patient, okay, very frequently, not just admit and prescribe treatment. Because this is an important point of your colleague. He said, number one is the observation, diagnosis, monitoring of the patient. Close monitor will save the life. Okay, neglect can threaten the life. Okay.
Thank you, doctor.
You are welcome. You are welcome. Thank you. Assalamu alaikum wa rahmatullah.
Waalaikumsalam.
Thank
Thank you, doctor.
Thank you, doctor.
Thank you, doctor.
Thank you, doctor.
I will, but I feel it is a bit difficult for you. Okay, let us go, inshallah.